Hi there, and Gal, thank you so much for the introduction. It's a privilege to be with you all here today in this virtual community. My name is Sara Coffey. I'm a child and adolescent psychiatrist and the director of child psychiatry at Oklahoma State University Center for Health Sciences. And I also serve as the director of clinical operations for the Department of Human Services Division of Child Welfare. And I really appreciate your all's attention and time today. And thank you guys for being here to talk. So I'm going to get my screen up so we can talk a little bit about what we're going to talk about. So today I thought it would be good to discuss the Oklahoma Pediatric Psychotropic Medication Resource Guide. And that is a mouthful. And so please let me know if you have a better way to describe the work that we're doing. But again, wanted to give you all a glimpse into this community partnership for the judicious use of medications in vulnerable youth. I also wanted to take just a moment to acknowledge that as we talk about vulnerability in our population, as we talk about adversity, ACEs, and trauma, to just be, to acknowledge the fact that here, even in Tulsa, historically, this is something that is certainly on my mind with the anniversary of the Tulsa race massacres, with the protests that are going on both nationally and internationally. It's a sensitive period, I think, as always it is. And so just to be mindful of our own self-care as we talk about these issues, and just an invitation to make sure you're taking care of yourself as well. So as we get started, just wanted to talk a bit about why are we talking about medications in youth? This comes from the Center for Disease Control. It really looks at the prevalence of mental illness in our population of kids. I'm sure I'm speaking a bit to the choir here, but we know that mental illness and emotional disturbances are not a rare occurrence in the youth in our community. This comes from some CDC data that acknowledges that as much as 13% of any youth age 8 to 15 will have an underlying psychiatric illness. Certainly with the concerns of COVID and the issues around quarantine and access to care, I think there's a real concern that this might actually been increasing in our community. And so it's something that we certainly want to make sure that we are on the lookout for, because we know that children and families that are struggling, really we can meet their need in a better way. Another way to look at this is kind of, again, from some Center for Disease Control data, is kind of distributing it by the age. So you can see here on the left-hand side, looking at depression in youth. Not as common in our preschoolers or 3 to 5 years of age, but certainly as kids are getting older, we see an increased prevalence of depression. The National Youth Resource Study shows that anywhere between like 15% or more of high school students will actually experience depression or have thoughts of suicide. Anxiety, again, is another prevalent condition that we see in our youth. And again, just to acknowledge the current state of how we are currently as an international community, anxiety is likely rising in our youth and with our parents and our communities. So just being mindful of ways that we can be on the lookout for this, that we can talk about it in a very normalized way as kind of a process of being human, so that we can make sure that we're supporting each other in this space that we're all in. On the further right-hand side, you can see the discrepancy of behavioral disorders, often more commonly presented in our school-age children. But again, just issues that we want to make sure that we're on the lookout for so that we can appropriately understand what is going on with our youth. We can kind of tease out what is driving the behavior and ensure that our youth and families are getting the resources that they need to support themselves moving forward. So I love this slide. It comes from the National Alliance of Mental Illness, or NAMI. I think it really drives home the importance of not only us talking about this with our children, with our communities, and with our families, but also the acknowledgement that the majority of mental illness really starts to present itself early on. And you can see up here in the top left-hand corner that by 50% of all lifetime cases of mental illness are thought to begin before the age of 14, and 75% before the age of 24. So what does this mean for us as a community? Well, for me, it means that we need to be talking about this with our children, with our families. We need to be looking for this in our school settings, in our church settings, in our primary care offices, because what often happens, and as you can see here, is that the average delay between onset of symptoms and intervention is anywhere from 8 to 10 years. And so as a clinician, as somebody that treats kids that are really struggling in school and in social environments, to know that these issues have been going on for years at a time without kind of effective intervention or finding supports, it can be very disheartening and certainly can be really troubling and traumatic for children and families. And what is likely more concerning is that by age, about 50% of students age 14 or older with mental illness will actually end up dropping out of high school. And so we want to make sure that we're talking about these issues in childhood, that we're normalizing having a conversation about our feelings, about our behaviors, about our moods, so that we can appropriately understand what's going on, get the appropriate interventions in place, and to make sure that kids are able to live a healthy, productive, happy life. Furthermore, as you can see here at the bottom, is that 70% of youth in state and local juvenile justice systems will have a diagnosis of mental illness. As someone that does a lot of work with our partners with the Oklahoma Juvenile Affairs, I think it's not uncommon to see that this percentage is likely higher. Unfortunately, our kids end up falling through the systems, end up finding other ways to cope, whether that be with substance abuse, whether that be kind of affiliating with other individuals that maybe have more problematic behavior. We can do a better job as a community to talk about these issues, to make sure that we're supporting each other. Probably the most concerning thing as a community and as a mental health professional is recognizing that suicide remains the second leading cause of death for our youth aged 10 to 24. And actually more recently looking at CDC data, this is extended from 10 to 34 years of age. So we're losing our children, our adolescents, and our young adults by suicide, really without adequately diagnosing and treating and getting those interventions in place. So I put this up here as just a reminder to us that we have a long way to go, but certainly I'm optimistic that we can do better. But it really takes that community involvement, that collaboration between systems, between providers, to really make a big difference in the world of youth that are struggling with mental illness. So again, I'm assuming I'm preaching to the choir here, and if you haven't heard about ACEs, now's your chance. So Adverse Childhood Experiences is a study that is near and dear, I think, to many of our hearts. As a daughter of a social worker, as a former case aide in child welfare, it's not surprising to me, and I think to many of us, that adversity really leads to poorer outcomes later on in life. The ACEs study I love because it comes from our medical friends that really are also understanding this as well, that having adverse childhood experiences really leads to problems later on. We're talking about ACEs now, not only in medicine, but in schools and communities. Oklahoma is doing a lot of work around adverse childhood experiences with the Trauma Task Force. It is time that we start talking about our marginalized communities, our struggling communities, and recognizing that whenever this is occurring, it's leading to poor outcomes for them. And I think we're actually doing we're moving that forward here in Oklahoma, which is great because unfortunately, and I'm sure many of you all are aware, is that Oklahoma really remains at the top of having 4 or more adverse childhood experiences. So we're kind of a hotspot of adversity. But again, on a flip side, I think that means there's a lot that we can do to improve the health of our community. So I also think it's important for us to acknowledge when we're talking about ACEs, we're talking about interpersonal trauma, right? We know that adversity comes in a lot of shapes and sizes. We know that traumatic experiences come in a lot of shapes and sizes. But when you look at adverse childhood experiences and the ACEs that bubbled out as being more likely to cause these kind of issues later on, as you can see, the majority of them, if not all of them, are really interpersonal, right? So it's individuals that have been victims of physical, emotional, and sexual abuse, physical and emotional neglect, or household dysfunction, what's happening in the home, whether that be mental illness, an incarcerated relative, domestic violence, substance abuse, or divorce. All of this are issues that are happening in the home, right? So it's not something about being in a car accident, which would certainly be traumatic, or being a victim of having a tornado kind of blow your house down, which again is not to say that's not traumatic. But when we look at adverse childhood experiences, it's this interpersonal domain that's happening in the home. And again, as the Director of Clinical Services for Child Welfare, this is a mirror for our kids that are in the child welfare system, right? As mentioned, oftentimes there's comorbidity with ACEs. You often don't have one without the other. And unfortunately, the more ACEs you have, the more likely you are to have difficulty, not only in childhood, but later on. And that's not to say that we can't have resilience and overcome this adversity, but it's important for us to be equitable in the way that we're kind of viewing people's experiences and recognizing how that plays a role. I also think it's so important for us to understand that this is not just something that, that happens without any biological consequence. And the great thing is that as we understand more about how adverse childhood experiences lead to these deleterious outcomes, it causes us to really take pause and to really understand how we get there. So this is your neuroanatomy lesson for the day, and it's pretty rudimentary. I hope that's okay. But what we think is happening and what we're seeing is happening in functional MRIs, these great MRIs that show us the brain in real time, is that there are real noticeable changes, right? And so individuals that have had a lot of this developmental or complex trauma, a lot of this adversity, their brains might look different than those that have not. One way to think about this too is there's this great part of the brain called the amygdala, this part of the brain that we think is involved in our fight or flight response, right? This was an older part of the brain that kept us safe during times whenever there was a lot of stress, right? So we'd be on edge, our pupils would dilate, our heart would beat really fast, and our muscles would be able to run if a predator was kind of trying to attack us. This is an important part of our brain. When I'm walking across the street and a car is zooming past me, I want my amygdala firing up so I can jump back very quickly. I don't want my prefrontal cortex here telling me, oh, Sarah, that car is moving quite quickly. You might want to take a step backwards. That's too slow. I want my amygdala to really tell me what to do right away. Children that come in really chaotic environments that maybe are experiencing a lot of domestic violence or abuse, their amygdala is often fired up all the time, right? So they're having to be on edge. They're having to be hyper attuned at times to their environment. Sometimes it shuts down and they're hypo attuned as a way to kind of protect themselves. But oftentimes what will happen is that they'll really be in a stress response environment and their brain is kind of experiencing some changes. And so this is a struggle because all of the energy is really kind of put in this fight or flight response. And these other areas of planning, of regulating, of being able to kind of engage in the world whenever things would be safe might not be fully on board. And what we're seeing in functional MRI studies is that there are really noticeable changes. And so it's important for us to note that there is an underlying biological change that's occurring, and we need to do better to get at the root of what's really driving our behavioral and emotional disturbances, rather than just kind of slapping on something that treats the symptom. And we'll talk a little bit more about that and how it relates to these guidelines. So I found this slide online. I use it all the time. I think it's a great slide. It comes from our friends in the Ohio Department of Education. But another way to think of this too with regards to children and learning and kind of how they're using their brain is that in typical development, whenever kids come from a very safe environment, whenever they've had caregivers that have been able to model for them how to regulate their emotions, whenever they've had some good practicing and kind of social and emotional reciprocity, they come on board for fully kind of cognitive processing, right? So they have the ability to come to school, to learn, to engage with each other because it's kind of all in play. Oftentimes what we see in issues with developmental trauma and a lot of adversity is that it's flipped on its head a little bit. Instead of being able to really engage in the world with your full cognitive processing going on, oftentimes our friends that have really struggled with a lot of this stuff are really struggling just to survive. And so a lot of their energy is really used to make sure that they're keeping themselves safe, and rightfully so, right? If we're not feeling safe in our environment, if we're constantly having to be on the lookout for a threat going on, it's going to be a lot harder for our brain to have the energy to be able to be used in regulation, in social and emotional reciprocity, or even in cognition. And now that's not to say that this is always online. As a mother to 2 small children and has 2 dogs in their home, that's working from home, that's teaching from home, as a human, I get dysregulated sometimes. My kids get dysregulated sometimes. We all get dysregulated sometimes, and that's okay. But it's important to know that with this pattern of behavior, we're really doing our best to ensure that we're safe, that we're taking care of each other. And oftentimes, whenever a lot of adversity and trauma has gone on, that's flipped. And so it's important for us to know what our baseline is and to help each other be able to be safe, to regulate, and to work with each other. And we'll see how this ties in specifically with some of our kids in child welfare as well. So as I mentioned, a lot of this talk about these guidelines really comes from an understanding of how we're treating kids in the child welfare system. And we'll get to that in just a bit about how we get to these guidelines through the work in child welfare. But I want to first talk about kind of the history of how we get there. So this comes from a study that was presented in the Journal of Family Violence that was looking at really some symptoms of kids in the child welfare system. And in the study of kids in the child welfare system, what they noticed was about 70% of them were really struggling with functional impairment. And so they were struggling in school, they were struggling in their peer relations, they were struggling in some domain in their life that really called attention to them, right? These are likely kids that had disruptive placements, that maybe were ending up in residential placement settings, but something was not working in a way that was allowing them to heal and to be helped. I think it's also important to know that with these kids that not a lot of them actually met criteria for post-traumatic stress disorder. And so only about 30% of them had a diagnosis of PTSD. And this matters because if you have a diagnosis, we have evidence-based treatments to help them. And the intention is that once we have an accurate diagnosis and we have accurate evidence-based treatments, that things will get better. But unfortunately, those kids might not carry that diagnosis, but we know that they're struggling. So they might struggle with affective and psychological dysregulation. So although the underlying kind of cause of their difficulties might be due to relational trauma, might be due to the disruptive placements that they had, might be due to kind of a PTSD or complex PTSD symptom. They might not meet criteria for PTSD, but they might struggle with affective psychological dysregulation. They might meet all of the criteria for a diagnosis of disruptive mood dysregulation disorder, or perhaps bipolar disorder, but the core of what's driving it might be different. They might struggle with attentional and behavioral dysregulation. So although the core of what might be really driving their behavior might be more trauma-induced, they might meet criteria for attention deficit hyperactivity disorder. They might struggle with self and relational dysregulation. So in older adolescents, they might be deemed to have borderline personality disorder traits, right? But what's really driving it is these issues around attachment and relationship. That's not to say that they might not have comorbid diagnoses, that there might not also be a true kind of genetic disposition to struggle with anxiety or with bipolar disorder or with attention deficit hyperactivity disorder. But it does mean we need to think more contextually about the way we understand how our children and how our youth are struggling and make sure we're getting at the core of it rather than just treating the symptoms of the disease. And that's what we aim to do as well with this resource guide. Because if we don't look at kind of the core of what's really driving, what happens to a lot of these kids? And what we see happens to a lot of these kids is this, right? In our best efforts to kind of treat the symptoms, we end on throwing on medications to treat the symptoms of the disease rather than really getting at the core of what's driving. It's kind of like having a fever due to pneumonia, but just giving Tylenol, right? That might help the fever, but it's not really getting to the cause of what's driving the disease. And I think coming together as a community with this resource guide with clinicians and pharmacists and us together is really to make sure that we are doing our best to be judicious about medication use and helping clinicians to understand the best way to ensure that we're looking through a trauma-informed lens and doing our best to ensure that evidence-based therapies are in place for our kids that we serve. So as I mentioned, a lot of this work really got started looking at kids in the child welfare system. The kids in child welfare really represent a vulnerable population. As we mentioned, it's very much like holding up a mirror of the ACEs to this population of kids. Oftentimes kids, whenever they're removed from the home, might have multiple placements. And so continuity of care can become quite an issue, right? So you might have one clinician that's really doing the best that they can to understand what's going on. I can tell you, I'm certain that there are times where the kids' behavior is so disruptive that they're kicked out of school, that they're at risk of being very aggressive. And so I do think that clinicians are really doing their best to make sure they're keeping kids safe, doing their best to make sure that kids can be maintained in a family-like environment. But unfortunately, what happens is that we often do use these medications as a way, I think, to treat the symptoms, but maybe aren't as effective as they really could be if they were used more judiciously. So this comes from the Congressional Research Service, which shows, kind of looking here, about the number of medications and kind of what the placement looks like for kids in child welfare. Blue represents 1 medication, red is 2 medications, and green is 3 or more. And as you see here, kind of in the in-home setting, more than likely the majority of the kids that are taking a medication is 1 medication. As it goes into formal kinship care, we kind of see an added on of 2 medications. And as we move all the way over to this group home or residential care, what we see is that the majority of kids end up on multiple medications. This is something that is pretty consistent nationwide, and which was really a call for, I'd say, state-serving agencies to take a look at how we use medications in child welfare. And what was really the impetus for starting these psychotropic medication treatment guidelines. Now, across the nation in many child welfare settings, kids in child welfare, depending on what state you are in, typically have their own kind of carve out of medical insurance. So it's typically a partnership with that medical insurance provider, working to kind of develop some best practice guidelines, maybe some qualities for review. Fortunately, in Oklahoma, our children in child welfare are under state Medicaid as well. And so we've actually partnered with the Oklahoma Healthcare Authority to bring together a task force to kind of look at best practices, to really look at the literature, to provide a resource guide for clinicians that are caring for kids, not only in child welfare, but quite frankly, any kid that's coming into the primary care setting. And we'll talk about why that's important too. So as I mentioned, I'm a child and adolescent psychiatrist. I don't know if you guys know this, but there's hardly any of us. As you look here, this is a map from the American Academy of Child and Adolescent Psychiatry, looking at shortage areas. So I'm an OSU child psychiatrist. So for our crimson and cream folks, we did a really good job of making this bright red for you. But you can see across the nation, there's a severe shortage in child and adolescent psychiatry. Even in New England, as well as the tri-state area, there's still considered to be a high shortage. Nowhere do you find a mostly sufficient supply of child psychiatrists to really kind of take a look at kids diagnostically and to aid in assessment and treatment of psychiatric illnesses. And so what happens, which is true really quite frankly for both adult and for child and adolescent mental health care, is that the majority of it is really kind of first looked at in primary care settings. And that's okay. We want our primary care clinicians to be able to triage appropriately to make sure that they can kind of do the referrals for evidence-based therapy, and when indicated, use medications judiciously whenever they're treating kids, because to get into a child psychiatrist, wait lists are often very, very long. And quite frankly, there's not enough of us to go around. So it aids us in thinking more systemically about a way that we can help support in the primary care setting. And we'll talk a little bit about that. So I wanted to offer a bit of some examples that come my way. As I mentioned, as the director of clinical services at child welfare, oftentimes I'll get referrals. I'll also add as the co-lead of our pediatric behavioral and emotional health echo. We often staff cases on there as well. So this is a bit of a snapshot of some of the kids that come my way, just to give you a glimpse into what we're talking about. So this was a young child that was in the child welfare system, an 8-year-old that's currently in residential care. The medication list included Topamax, guanfacine, Quilichu, methylphenidate, Vraylar, Seroquel, and Latuda, all of which are psychiatric medications. And the question posed to me is, he's new to the system and we aren't sure why he's prescribed these. I wish that was an uncommon statement, but it's often very common. I think a lot of this is due to certainly continuity with kids, but I will tell you, I've certainly served in outpatient clinics where I've had other families come my way that weren't in the child welfare system and still don't have a clear understanding of why they're taking medication. We can do better, and we should do better as a community, that there's informed consent, that both the caregivers as well as the kids have an understanding of why they're taking medication, what the side effects of the medication are, and what is kind of the plan for coming off of them. And so we'll talk a little bit more about how the resource guide can help support that. So another common situation I see, this is a 17-year-old that's on fluoxetine, pimozide, chlorpromazine, atomoxetine, prazosin, imipramine, clonidine, desmopressin, with the concerns that he seems tired and sedated. Do you think the medications might be contributing? Yes, I do. So again, I think it's important for all of us to know. And from a strengths-based perspective, I will say, again, I think clinicians are doing the best with what they have, with what they know. You know, we know these medications can be useful in some regard. However, this is a lot of medication. It's important for us to know too that there really aren't a lot of studies on what we call polypharmacy on these multiple medications. Knowing how they interact is also something that is not very well studied. Many of these medications listed here can cause sedation, and it's not uncommon if they're prescribed together that they can actually increase the potency of each other. And so again, we're doing the best with what we can know, but we need to have some informed consent about why we're on the medication that we're on.
Dr. Coffey, there is a request to go back to the previous slide. Yohaira, would you like to say what you are looking for?
No, I was just writing notes and I was missing a few of the action medications. Thank you.
You're welcome. Are you all set up with that now? Okay, holler if you're not, but we'll keep going.
Yes, thank you.
Okay. So then another example might be a child that's on hydroxyzine, Latuda, guanfacine, Zyprexa, Tegretol, Desresol, Vyvanse, Lexapro. I think they're on too many medications. I'm not quite sure why she's taking these. These are conversations we need to have. They're conversations that we need to have about our youth. Again, I think there's a lot of systemic factors that contribute to this kind of piling on of medications, but it's important that as a community, we're advocating for judicious use. And quite frankly, it's also important that our clinicians have a resource guide to kind of look at to make sure that they can provide appropriate use of medications. And that's really the impetus of how a lot of these resource guides came to be. And we'll talk a bit about how Oklahoma's came to be. So with all that being said, this is how we get to the Oklahoma Pediatric Psychotropic Medication Resource Guide. And you can see here it's in partnership with OSU CHS. We're also working with the OU College of Pharmacy in Oklahoma City, the Oklahoma Healthcare Authority, as well as the Department of Human Services Division of Child Welfare. And I'd like to say, you know, this really wouldn't have come to fruition if it wasn't for the guidance of Dr. Deborah Shropshire, who is a pediatrician and who is the current director of child welfare. I think that her bringing together the group to kind of come together and to put these into place is very important and instrumental, and will serve as a wonderful guide for clinicians out there in the community doing their best to provide care for kids with psychiatric illnesses. I also want to make sure that we acknowledge the Telegen Community Initiative, which, if you don't know about them, does a lot of really great work in Oklahoma, Illinois, and also Colorado as well, actually. They have provided some grant funding to help support the work of this resource guide so that we can get it out to clinicians as a valuable tool that they can use in treating kids with psychiatric illnesses. As I mentioned too, if you guys have not had the opportunity to sign on to our Pediatric Behavioral and Emotional Health Echo, I'll make sure to get the link out to you. We meet every Tuesday at noon. So tomorrow we'll meet at noon. We meet virtually just on the Zoom platform as we're doing here. We're actually using our Echo to talk about the resource guide. Tomorrow we'll have Dr. Tara Buck talk about her topic of discussion, which was autism spectrum disorders. We also provide time for case consultation. So I'm one of the, I'm going to put in air quotes, expert on the team as a child psychiatrist. We have another child psychiatrist, a pediatric psychologist, a pediatric neuropsychologist, and a pharmacist on our hub team, as well as wonderful participants that call in. So we have family medicine docs, counselors, therapists, adult psychiatrists, and the whole community comes together. And I'll tell you, as we started our Project Echo, I thought, what a great gift this will be to the community to put it out there. And I will tell you, I'm often the recipient of gifts from the community to come together and to collaborate on kids that are really struggling, are real vulnerable populations. To work as a team is such an important piece of what we can do for families. We'd love to have you guys come on if you want to. And so we're talking about these guidelines on Echo every Tuesday, really through September, because it's a pretty extensive book. So who is this task force? So we included several child psychiatrists across the state. Many of us are in academia, but we also included community child psychiatrists, psychiatrists in private practice, also child psychiatrists in both inpatient and outpatient practice. We had pediatricians and pharmacists on our team as well. And really, we met together, it was almost a year ago, to come together to talk about our specific topics, doing extensive literature search, as well as kind of looking at best practice here in Oklahoma to ensure we can have a robust resource guide for clinicians that are caring for these vulnerable youth. Some of the topics that we cover include aggression, attention deficit hyperactivity disorder. You can see depression, disruptive mood dysregulation disorder, eating disorders, insomnia, nightmares. We also touch on the use of complementary and alternative treatments. As Oklahoma is a medical marijuana state, this is something that is becoming more prominent as family members come in to talk about treatment options. And we wanted to make sure that we provided our clinicians with the most up-to-date research on what complementary medications should and should not be used, and the research behind that as well. As I'm sure many of you know too, in working with children, that a 4-year-old is not the same as a 14-year-old, right? And a 2-year-old is certainly not the same as a 16-year-old. And so in addition to looking at kind of these developmental trajectories between age 5 and 17, we have an entire section dedicated to the treatment of younger children. And so Dr. Cheshire, who I think was on one of these Haruvs from the couch earlier, and who is an infant mental health specialist, really led a lot of the research and kind of compiling of how to work with families for children age 5 and younger. We focus on attachment disorders, anxiety disorders, obsessive compulsive disorders, and the list you can see here, to ensure that our clinicians, whether it be pediatricians, PAs, adult psychiatrists, nurse practitioners, family medicine docs, have an understanding of some of the differences there. And so we'll talk a little bit about that too. So as I mentioned, the resource guide is really, it's intended for clinicians that are caring for kids, but clinicians is a broad term, right? And so in addition for prescribing clinicians that are prescribing medication, also being available for therapists and for others in the community that want kind of best practice of what this looks like. We are in the final throes of really wrapping this up. And so it's at not my copy editor, it's at our marketing department right now. And we'll have an online version available to the public, as well as some hard copies that will be distributed to the community. But the way that it's crafted is we talk about some general principles of prescribing medications, and I wanted to tell you guys a bit about these today. These are best practices that I think are important for communities, for families, and for patients to know about. And then I'll also talk a bit about the anxiety for littles, so you can kind of get a sense of how it is presented in the guidelines. When we think about general principles of prescribing, it's important before we prescribe really any psychiatric medication that there's been a thorough psychiatric evaluation. And this should include, when necessary, a medical workup. It should include collateral information. I can't tell you, so I did my training outside of Oklahoma in Massachusetts, and when I came back and started practicing here, I called a therapist that we were, sharing patients. It was surprising to me how surprised therapists were to hear from the psychiatrist. This is disheartening to me. Because really we should be communicating with each other. We should have an understanding. I should know what you see. I should know what the school sees. We should be working together in a patient-centered approach to understand that we're seeing all pictures of the crystal here. So it's really making sure that we're encouraging that. Again, from a systemic component, understanding that oftentimes in busy clinical practice, having the time to do that collateral seems like more of a luxury. I'm thankful that the Oklahoma Healthcare Authority is involved, because I think as we come together to recognize it is essential for collaboration, my hope is that we'll find funding mechanisms to ensure that that is happening, and other ways to ensure that collaboration is occurring, because you can't do it alone. I just don't think it's possible. We also want to make sure that we're obtaining past medical history, right? From both outpatient and inpatient treatment. And again, this can often be a systemic thing. HIPAA and other requirements kind of can prevent us from communicating with each other. Unfortunately, I think in mental health, we kind of continue to stigmatize ourselves and not want to share that information. I think there should be a notion of being able to share the as needed information to know if a child is being treated for anxiety or ADHD. These are These are just as, biological mechanisms as asthma or diabetes, and they can really impact each other if we're not talking with each other about what's going on. To normalize this and to not stigmatize it is an important piece of the work that we need to do. We also really talk, and I'll tell you, as you read the guidebook, you'll hear how often we talk about the importance of screening for trauma. Specific questions about trauma and safety should be a part of every assessment. And as I mentioned earlier, especially in Oklahoma, where adverse childhood experiences really are so high, it is imperative that we're asking about this with our families in a very trauma-informed way, that we're understanding the implications of multi-generational trauma, recognizing that parents in many ways are just doing the best that they can, the best that they know, but we can help them to understand how they might be impacting the health of their children in a very collaborative and trauma-informed way. And really, the prescriber of psychiatric medications should develop an interdisciplinary psychosocial and psychopharmacological treatment plan based on best available evidence. And so I used to say, oh, I wish I had a medication that could fix everything, but quite frankly, I don't. Because we know that the work that we do in our day-to-day lives and our relationships and our behaviors matters. And really, I think it's important for us to emphasize that as clinicians. Medications, specifically in kids, often play an adjunctive role, and we'll talk more about this. It does not mean that medications are not indicated. In many cases, they are, but we need to highlight the importance of behavioral therapy, of the relationship building that goes on, and to prioritize that with our families. So I made this one really big because, again, I think this is important that us as clinicians, and for really just examining the evidence that we're aware of, especially for kids, especially the younger the child is. The majority of psychiatric diagnosis, the first line is including is behavioral therapy that includes caregiver participation. It's indicated as the first line treatment. We really need to start there, and we need to start those conversations with our families early. It's not uncommon that I'll have children that without having a clear diagnosis of what's going on might look like ADHD, and we're prescribed an ADHD medication, and it might help a little bit, but it doesn't help with everything else that's contributing. And so now there's this kind of implicit wish that the medication is going to treat it whenever there's all this other stuff going on. We have to do a better job of educating our families about the importance of caregiver participation and the healing process of what we're dealing with. I think another thing that's real important too for all of us to be aware of is to make sure that there is assent and consent of the parents. So as adults, we can consent to medications. We should know why I'm taking the medications, what are the risks of taking it, what are the risks of not taking it, and making sure that I have a clear understanding of why I'm starting something. Same thing for children. And although they can't necessarily consent to medication, they can certainly assent to medication. They should know why they're taking it. And certainly older children, to give them a sense of agency, they should have an understanding of what their diagnosis is, what that means for them, and why they are taking a medication. And so it's important that we advocate for this with our clinicians. Again, it's important that we're having these contextual conversations so we know what we're putting into our bodies. And again, we should be able to talk about what are the risks for taking and what are the risks for not. Because certainly, especially in more severe cases of psychiatric illness, without taking medications, risks can be quite high. And so we want to make sure we're having those conversations together. It's also important for us to know that the prescriber needs a clear rationale for using medication combinations. So again, this term polypharmacy comes up quite frequently with our youth. And it's important to know that there has not been a lot of studies to show that use of multiple medications is beneficial, right? And if multiple medications are indicated, really we should only make one medication change at a time. This is important because medications can have side effects, and if I start 2 medications at once, and maybe there's an adverse effect, it's hard to know which medication this is. We should have conversations about what to expect whenever we start medication. Additionally, other than cross-tapering, which means kind of coming down off of one medication and starting another, there's no evidence to support the use of 2 medications from the same class being used simultaneously, and this should be avoided. On one of the, actually I think on a couple of the slides that I showed you, there was an indication of a child being prescribed 3 atypical antipsychotics. For the life of me, when I look at that as a clinician, I have no understanding as to why they're on all those medications. Many of the studies that have been done on medications are just focused on one medication alone. And so we don't know how they interact with each other. And so it's important that we're having conversations to know why we're starting this medication, what are the potential side effects of the medication, and when should I call you when I'm worried? Because we know that kids can have adverse reactions, and we want to make sure we're judicious in our use of medications. So the general prescribing is just kind of a brief summary of some of the information that we relay to clinicians. I'll tell you, in part of my work with this task force, I've gone and talked to family medicine residents and other people, and I ask them, does this seem okay? Like, is it too much? And the feedback I get is, no, doc, it's not too much. This is good. We need to hear this. And so I don't think we're asking too much of our community to have these real important conversations with families. I want to offer for you too a bit of what this kind of looks like. So as a clinician kind of maybe has a young child that's coming in, they're concerned about anxiety, they can flip to the pages in Anxiety in Children and learn a little bit more. This is what they'll find. So as I mentioned, Dr. Cheshire did a lot of work around this. There thankfully has been quite a bit of research with young children, and this is what we talk about. So we start off with some clinical pearls with anxiety in young children. And so recognizing that the occurrence of anxiety disorders in young kids is about as similar as it is in children and adolescents. So it's not uncommon to find anxiety in young kids, but also important for clinicians to know that there's not a lot of research on the use of medications for anxiety in young children. And again, if you can kind of picture being in a busy primary care office, you know, a new patient comes in, it's a mom of a 4-year-old who has an 8-year-old who had no problems, and their 4-year-old, you know, won't leave the home and is really struggling, and mom's frazzled and freaked out. And, you know, the pediatrician with their best intentions, you know, says, well, let's just start some fluoxetine. You know, it worked for Sally, who's 16, maybe that will work for you. It would make sense to me as a clinician why you would do that, right? You're doing your best to treat the symptoms, to kind of help mom out, to help the kid out. But important to know too, there's not a lot of great evidence, and there are things that we really should do beforehand to ensure the kid's getting the appropriate care. And part of that is because there's a lot of effective psychotherapy treatments for kids with anxiety disorders. And so we want to make sure that kids are getting the help that they need. Another clinical pearl that's mentioned is that younger kids really should be referred to an infant mental health specialist. Again, as someone that practiced in Massachusetts for training, I was not aware of how robust infant mental health is here in Oklahoma. Important for all of us to know that I think Oklahoma is really advocating for infant mental health specialists. I will tell you that I think if I don't know about it, I'm guessing there's other psychiatrists or pediatricians or family medicine docs that don't know about it as well. And so this resource guide really makes sure that we let people know about the available resources in the community so that we can connect kids to those individuals that can provide that care. And again, parents of young children with anxiety disorders often have anxiety as well. And there's actually been a lot of really great studies that show that if you can help the parents' anxiety get better, that kids' anxieties gets better as well. So just a lot of ways to appreciate it. There's a lot of really great rating scales that can be used in a primary care office to kind of assess and track how kids' anxiety is doing. Dr. Cheshire mentioned a lot, but I've kind of truncated a few. But we give the example of the Spence Preschool Anxiety Scale, as well as you know, a link to attach to it. The Survey of the Wellbeing of Young Children is another one, again with the rating scale link attached. And then we go on to talk about the treatment approach. So again, important to know, so as a child psychiatrist, I've done 4 years of medical school, 3 to 4 years of adult psychiatry, and 2 years of child psychiatry. And that's pretty extensive for child mental health in the medical world. Pediatricians, they might get some didactic training. Maybe they've done a month of child psychiatry, but not a whole lot. Adult psychiatrists as well, family medicine docs. They're not really aware of all the evidence. And so we wanted to make sure that we are giving them the specific evidence models that are helpful for individuals so that whenever they do have a concern of a child having anxiety, they can make a targeted referral, right? So rather than just a blanket referral to maybe a therapist that worked really well with their 17-year-old teenager, but maybe doesn't have that expertise or doesn't have that level of training, they can make sure that they're helping the family connect in an effective way. And you can see here, we talk about first-line treatment with strong recommendations, second-line treatment, and then third-line treatment would be that fluoxetine. I will tell you, especially in our younger kids, for the most part, what you'll see is kind of the evidence-based therapies. But again, just letting clinicians know that there's often a lot of work to do before we get here to the bottom. And that's what we want, right? We want to triage appropriately. We want to ensure kids get appropriate treatment. And we want to use the medication whenever there's severity or there's a sense that the other first and second line treatments have not been effective. We do our best to provide some additional resources for clinicians if they want to get some additional information. And as most documents, we make sure that we're referencing all of the literature that we came from. So as I mentioned, we're in the final throes of getting this together. I'm hoping actually in the next few weeks, we'll have an online version. The intention is for that every 2 years that we'll meet together as a task group and kind of redo the resource guide so it's available for our clinicians. And we just continue to move forward. So again, I just want to, I'm happy to entertain any questions. I think this virtual platform is a great way for us to come together as a community, and just really appreciate your guys' time today to talk a bit about the work that's being done here in Oklahoma.
Thank you. Thank you so much. Wow, it was so interesting. And I was just thinking about all the kiddos that I saw during the years as a social worker and as a child protective officer that got so many medications over the years just because the system didn't know how to help them, not because it was the right thing to do. I mean, right. They all moved through my head, you know, and I was just, oh my gosh, if we just had this lecture 20 years ago, or 15 years ago, or 10 years ago, or now. Thank you.
You're welcome.
Thank you for this. Do we have any questions for Dr. Coffey?
Yes, Gal, there's a couple questions already in here. So the first one is, how often do you think meds are prescribed to children that are not tested on children?
So that's a great question, and I'll do a two-parter. So I think it's important to know the difference between like an FDA-approved medication and then and recognize that just because a medication is not FDA approved does not mean there hasn't been, you know, tests to see about its effectiveness. So that's one thing. Because what often happens is that a medication will be FDA approved to treat adult anxiety, but there'll be research that's done that shows it's effective for kids, but they won't seek FDA approval. And so I will say that in the resource guide, really the majority, if not all, I might say, of the medication recommendations have research to support them. There's different levels of research, right? So we think of the gold standard of research being the double-blind randomized controlled trial, right? So we have 100 kids split up 50-50. We don't know if they're taking sertraline or if they're taking a placebo, and we see how they do better. But sometimes we're not able to do that, and so we might have case reports. But quite frankly, I think every good clinician should be looking at the research to ensure that there is some good research to support it. But sometimes you are using your clinical discretion to say, hey, you know, I heard this worked very well. I'm giving my family the pros and cons of trying it, and then moving forward. As far as the percentage of time, I don't think anybody has a really great answer to say, oh, 20% of the time they're not tested. I think for the most part, there has been some evidence to support that it's been effective in some population. Sometimes it's been tested and it hasn't shown to be beneficial, and I've seen clinicians use it either way, and that's where I think it gets a little bit murky. Great question.
Thank you. So the second question is, where will the guide be available online?
Great question. So I think it should be available on OSU CHS's website. I believe we're also trying to get it available through the Oklahoma Healthcare Authority website and through the OU College of Pharmacy. What I will do is once we do have a link available, I'll make sure to kind of share it with you all. And I'm hoping there'll be a lot of information kind of statewide about its availability.
Thank you. Do you recommend a child who has multiple meds go off all meds to reevaluate?
So I think it needs to happen, that also needs to happen judiciously, right? And so I think it really, what first needs to start is a conversation with the prescribing clinician about your concerns, right? You know, I'm concerned about all the medication they're on. I'm concerned about the side effects. in the resource guide, and part of it too, guys, is that there actually isn't a lot of really great research to support how to come off medications. There is some, and this is also detailed in our resource guide as well. Quite often we recommend, you know, stopping the medication that was most recently added if it doesn't seem to be effective, but tapering down again, because sometimes just stopping all medications at once can be very problematic. As I mentioned, we don't want to start more than one medication at a time. We don't really want to stop more than one medication at a time either, because if we stop several, we might not know what the effect is. So quite frankly, I think it's important to be judicious about that and typically kind of go low and slow coming off and being mindful about how we come off medications. I always think it's good to be having conversations with your clinicians about, why am I taking this? And how long do you think I have to take this for?
Thank you. Okay, so the next one is kind of a description of a specific situation. I work with juvenile probation, children ages 12 through 18. When you have a 17-year-old who is using marijuana daily, diagnosed with major depressive disorder but does not want to take medication, has dropped out of school and has been in outpatient counseling for 1 year, what would be the next step? Residential treatment for substance abuse, more outpatient?
That's a great question. So these are my favorite kids. And as a child psychiatry fellow on the adolescent unit, we used to be able to do a medication group with our adolescents, and inevitably every week it would come out, doc, why can't you just prescribe me marijuana? You know, like that's going to help everything. And I think it's an individual conversation, right? So I often have real frank discussions with my adolescents about, tell me what it does for you. You know, quite often they're self-medicating in a sense to kind of help them feel calm, to feel numb, and also the recognition that marijuana, just like other drugs, is a drug. And so I think it's an individual basis. I will say that I think the least restrictive setting is really going to be the most important thing for our kids. And so I'm not a huge advocate of residential or inpatient setting unless there's a safety concern. I think the other issue that would be important to have a conversation with is the family. Oftentimes our families, for what it's worth, have their own difficulties that they're struggling with too. And if we're having conversations with the teen about limiting their use of marijuana, but the parents are smoking in the back, I mean, it creates like a mixed message. So I think engaging the family, I think having frank discussions with the kids about what the substances are doing for them, and having more kind of pro-social ways for them to engage, whether that be through sports or through like hobbies and other things would be ways that I'd approach that. It's a great question though.
Thank you so much for your answer. As of right now, just kidding. Something just popped up. Okay, here we go. I mostly work with the 0 through 6 population. My biggest issue is the school district. Often the parents are given the need medication talk, which is illegal as the school isn't able to mandate medications. Some of the parents come in asking for the psychiatrist referrals to help with behaviors. I provide parent-child psychotherapy, and after a few sessions, they start noticing improvement in their children's behaviors, but it is a struggle to get the school to be trauma-informed.
I think that's a great question, and I think it really alludes to this notion that, you know, as mental health providers, like we're a piece of the puzzle, right? And that it's really important for us to collectively be as a community together, because from the school setting, from OJA, we heard from OJA, from child welfare, like it takes all of us together to be there. I will tell you again, I think one of the most important things we can do is to make sure that we're effectively communicating. So I don't always, but there are certainly times, I mean, I try to always talk to the teacher. So I think that you as a mental health provider, talking to the teacher to get a better understanding, sometimes there might be some miscommunication there, right? So it might be that the family is hearing, oh, he needs to be on medication. But what the teacher might be saying is his behaviors are still really problematic, but we might be missing that piece. So I always advocate to make sure we're talking together. In some instances, I go to IEP meetings so that we're all facilitating communication together too. I love the quote. I think one of the, and I'm gonna butcher it, I apologize, but it's like, you know, one of the hardest things about communication is realizing or thinking that we had it. Right? So we think we're all speaking the same language, but we didn't. And I think as mental health providers, the liaison part of what we do, kind of making sure we're all speaking the same language, making sure we know what the expectations are, and holding each other accountable is kind of the most important piece that we can facilitate in that relationship.
Thank you. If there's any more questions, we have 1 or 2 minutes, but as of right now, that was the last of the questions in the chat.
Those are great questions. You guys do an excellent job. Oh, I see another question coming in.
Yep. As a school social worker, I have found more time than not, the mental health professional is not fully informed, quick to blame or target the school, but slow to partner.
Yeah, I agree. I do. I think that's why we all got to talk to each other, right? Because I just think it's the most important thing. And again, I think as a clinician, sometimes you think you don't have time for it, but I would argue you don't have time not to do it. You know, if we can get ahead of it and find ways that we could communicate with each other, whether that be, you know, the initial kind of conversation and then it's through email or text or whatever needs to happen, give me a heads up whenever something's going on, doing a rating scale. It's like the allegory of the elephant, right? Everybody has their hand on a different piece of the elephant, but we don't really know what we're talking about unless we all come together. So I appreciate that, that insight. I think you're right. We got to talk to one another.
Oh, maybe we can think about doing something for school educators and maybe directors of schools, and give them a knowledge about this, which is very important.
I agree. I think they really bless their hearts. I think they also have a lot of challenging behaviors that they're having to manage in the classroom on top of doing a curriculum. And we got a lot of work to do, but we're stronger together. We're stronger as a community, and I don't think any one of us can do it alone. So.
Okay, so I think that we can say thank you and goodbye.
Thank you. Thank you guys for continuing to hold this community together. Gail, thank you guys so much for the opportunity to do this. Wishing you guys all peace and health and all great things moving forward. Thank you.
Thank you all. Thank you all for joining us. And then thank you, Dr. Coffey, for this important, so important lecture. Thank you.
You're welcome. Bye.